Hello and habari everyone. Thank you so much for joining us. We're really happy that you can join us today in our session, The Quest for Wellbeing, Adolescence and Mental Health. So this is one among the series of virtual workshops for HIV in adolescence. And this is the sixth one. We have had 5 of them already, as you can see on your screen. And today we are excited to have you all for our very wonderful session, The Quest for Wellbeing, Adolescence, and Mental Health. So I'm going to co-chair this session together with my wonderful sister, Georgina Caswell, who I'm going to welcome to introduce her very short. But before that, maybe I introduce myself first. My name is Rafael Dennis from Tanzania, Eastern Africa. I'm working with research institutions which work on adolescents and young people's participation, but also I'm a member of African Network, which is the network of NGOs in Tanzania which works on sexual rights and reproductive health. Okay. So thank you so much for joining us today. We're really looking forward to hear from you all. And as we proceed, I would like if every one of you could introduce yourself in the chat box. Just write your name, where you're from, and what motivated you to join this session. We'll be glad to read from you about that. Just write us your name, where you're from, and your motivation to join us today. I know we're really in a challenging time and there's a lot to do, but choosing to join us today, there must be a motivation behind. So we'll be really glad to read that. So let me welcome my co-chair today, Georgina, to introduce herself and take us to the next steps. Welcome, Georgina.
Thank you, Raphael. Thank you. It's really amazing to be here with you guys today. And it's really great to be co-chairing this session with Raphael. So my name's Georgina Caswell. I am head of programs at the Global Network of People Living with HIV, GMP+. And I live in South Africa. And this is such an important topic. This is a really important topic, and it's really exciting that there's growing recognition of the need to really be talking about mental health and to be doing something about it. So it's a real honor to be co-chairing this session with Raphael. So just before we dive into it, we just wanted both Raphael and myself to just kind of reflect on this particular topic. We were saying that, you know, there really is increasing recognition that it's an important area, an important sort of subject that to date hasn't been addressed sufficiently. So the fact that it hasn't been addressed sufficiently, but also amongst adolescents in particular and adolescents living with HIV, there remains a huge gap. There's loads to be learned about this topic. And interventions as well. There are some emerging interventions that are showing some really interesting results, and we're going to be hearing about those later today. But it's important for us to all listen, to ask questions, and to learn from each other. So in order to start, what we actually wanted to do was to start with a video. So there's a video which has been developed by Africade Jandiri, and it's a video on mental health. And it was developed in order to improve literacy around mental health amongst young people, to be able to understand the signs and the symptoms and where young people can go for help. So we thought we would start with that just to kind of bring us all into that space where we're thinking about mental health and what is it that we're talking about. So we'll start with that, and then we'll move on to hear from our keynote speaker, Cindy. So Karen, over to you to show us the video.
Hi, my name is Jaku. I'm here to talk to you about mental health. Some people think this means being mad or crazy, but it doesn't. It means staying healthy and feeling good in your mind and heart. There are a lot of things that can make our lives difficult, especially in times like this, where COVID-19 is changing the way we live. It's important to know that a lot of people worry, but there are things you can do to help yourself and others cope. So, what are some of these things you might experience? During hard times, You might feel anxiety, which is when someone worries a lot, or you might feel depressed, which is when a person feels very sad and helpless. When depression is severe, it can lead to thoughts of suicide. If you experience threats or violence, it can cause fear and worry that the threat might happen to you again. You might worry that COVID-19 is a threat to your life or to someone you love, which can result in these feelings. Depression, anxiety, fear, and worry can mean you don't enjoy life, or you have a poor concentration, or feel irritable and angry. These problems can also cause you to feel physically unwell, including having fast breathing, a pounding heart, poor sleep, poor appetite, and headaches. In stressful situations, violence or abuse may increase in homes and in families. Abuse of any kind is not okay, and you need to get help from a trusted person, no matter what the person doing the abusing says. You might be tempted to use substances like alcohol or drugs, thinking they will help you cope with difficult feelings, even though they may seem like they help in the moment. They actually decrease your ability to cope with stress and make anxiety worse. Violence, poor decision-making, and risk-taking behavior can all increase when using alcohol or drugs. So, it is very important to take care of yourself at times like this. Here are some things you can do to help support your mental health. Find someone to talk to about how you feel. Putting your thoughts into words and having someone understand can really help. Exercise. Even if you can't go out for a walk, do what you can in the house. Try jogging on the spot or doing exercises like squats or sit-ups. It helps to do this with someone else so you can encourage each other. Eat well and get enough sleep. Taking care of our bodies also helps our minds. Focus on things that are in your control. There are always things you can control and things you can't. Focusing on things you can't change will only make you feel more stressed. Think about things you can do and do them. You will see that you aren't completely helpless. Give yourself a break from the worry. Do things that take your mind off your problems, even for a little while. This could be watching TV, playing a game, dancing. Make a list of things that help you get your mind off your worries and try to do something every day. Do things that create change. This can be changing the problem or the way you see it. This might include talking it over with a trusted person, writing a journal to express your thoughts, or spending time in prayer. Listening to music and singing can change how you feel. Singing together with others in your household can also help a lot. You can also try to calm your body and mind through a breathing exercise. Sit comfortably and focus on your breathing. Breathe in slowly and deeply, counting to 4. Hold your breath, counting to 4, and then breathe out, counting to 4. Do this over and over for a few minutes. It should make you feel calmer. Practice this every day, even when you aren't feeling very stressed. You could share these ideas with people you love. It might help them too. And remember, it is more important now more than ever to take care of your body and your mind to stay healthy and happy.
Awesome. I hope you've enjoyed the video that I've presented. And I'm also delighted to see many of you writing to us, introducing yourselves, where you're from. There's so many, but I'll just go through some. I'm seeing Alice from UNICEF, Eastern and Southern African Region Office, Kanengo Zoe Bibusa Nakamba from Zambian Physical Hub. We also have Shanaz Kaperi and so many others, Sydney Monze from Zambia, Moses Nkesa from Kenya, Hulu Mulumba, Munachonga from Zambia as well. Keep writing to us. We'll be delighted to keep reading them. But now I would like to take you to our next activity, and we now have the keynote speaker for today's session, and it's Cynthia Meiser. I'm going to welcome her shortly to give us her keynote speech. But before that, I just want to give you a brief biography about her. So Cynthia Meiser is the national coordinator of the Organization of Young People Living with HIV in Kenya, Y+ Kenya, with extensive knowledge in advocacy, communication, developing and implementing adolescents and young people's programs. For over 6 years, Cindy has largely been involved in successfully national policy and advocacy campaigns, championing for the meaningful engagement of adolescents and young people, developing popular versions of adolescents and young people's focused literacy materials. So it's going to be an amazing keynote talk from Cindy, and let's welcome her. Karibu, Cindy.
Good day, everyone. My name is Cynthia Meiser. I am a 24-year-old Kenyan woman, and today I would like to take you with me to my 19-year-old self. On the 3rd of August 2016, I was scheduled for my usual clinic visit. When I entered the doctor's room, I immediately saw bottles of tenofovir, lamivudine, and efavirenz, commonly known to us as TLE. I was surprised because my usual treatment was just Septrin. My doctor informed me that everyone had to be initiated on ART because of the implementation of the new test and treat guidelines. I knew that I was living with HIV since I was 7 years old, and I knew that one day I would have to start taking ART. But still, this came as a total surprise to me. Nevertheless, I started taking ART, and already within a week, I started experiencing side effects. Commonly for me was the insomnia with extremely depressive thoughts. I never wanted to go out of the house, not even to school. I had low self-esteem. I stopped dressing completely. I was anxious all the time. I distanced myself from everyone and everything. All I wanted was to be alone in a dark room with completely nothing. I started to self-harm because that was the only way I knew I could express my frustration. Till a certain moment, I decided to stop taking my new medication and stick to what I was used to, that is Septrin. I mean, I was a healthy 19-year-old who was actively gaining weight and at the forefront of advocating for adherence for young people living with HIV. Yet here I was, struggling with adherence and dealing with the new side effects. While I previously never understood the real need for a support group, after 8 months, I found myself there for the first time as an adult. I talked about my challenges, and for the first time, I breathed out fully. It felt so good to let everything out. Everyone was shocked that I was not this perfect person, as I had studied health sciences and understood treatment better than anyone else. On that day, I found my support system that walked with me through my journey and even mentored me in my career. I share with you all this because most of the time people are just worried about young people not having access to medication. Well, there is a lot more to talk about. I was given medication, yes, but was never told on how to deal with the side effects that I would experience from taking this medication. This is the reality of many adolescents and young people living with HIV who struggle with adherence and self-acceptance. We experience depression, anxiety, and bereavement. Many times we have questions without answers, which exhaust us and affects us mentally. I want to highlight 3 key areas today that are essential to us as young people living with HIV, which will help us achieve better health outcomes. First, we absolutely need data to evaluate the long-lasting impact of ART on our mental well-being and subsequently the impact of mental health on our general well-being. Secondly, we need to integrate mental health within the HIV service delivery package. And thirdly, we need to prioritize funding mental health interventions in AYP programming. So let me start with the first area I have highlighted. We need data. The World Health Organization defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease. However, till today, there is much less data about mental well-being as compared to physical health. We need to recognize that everyone is prone to having mental health challenges that may manifest at different ages and times. More importantly, WHO informs us that mental health disorders typically start manifesting themselves from the age of 14 to 29. This age is prime for adolescents and young people, but we may fear the consequences of raising such issues, given the way the society often stigmatizes those affected by mental health challenges. In recent years, more and more young people have dared to speak about their mental health journey. But despite the needs of mental health among adolescents and young people being more visible, the prevalence of mental health issues among adolescents living with HIV is still not well understood. We simply lack data. The data is critical for countries to respond to our mental health needs and for us to hold our governments accountable. The lack of data hinders our advocacy and progress. We need disaggregated data on mental health to know what our needs are, not just the top-down biomedical data on health that is available to us right now. Remember that young people can play a key role in filling this gap. I am so proud to say that 2 global consultations being led by Y Plus Global on behalf of the University of Newcastle, Youth Stop AIDS, and WHO focused on the mental health needs of young people living with HIV. The second priority is that we need to integrate mental health in the HIV service delivery package. In our facilities, we completely lack tools that can be used to assist in assessing and identifying mental well-being. It is expected that once you self-assess yourself, you will directly open up to doctors or healthcare providers to get help. I believe a lot of young people do and will fall through the cracks of the system, majorly because it takes a lot of time to acknowledge that you are drowning in all this and you are the only one who can save yourself by first acknowledging you need help. These cracks and gaps have become even more acute during this COVID-19. Research has shown that 143 young people living with HIV in southern Malawi have undergone a research from July to September this year. And 72% have shown that they have feelings of depression at least once a month. And yet at the same time, healthcare providers are less able to respond because of their own levels of stress. A PATA healthcare provider survey carried out in April and May of this year with 188 respondents in 17 African countries found out that when asked about their current level of stress in relation to COVID-19, 26% reported they were quite stressed, 27% were very stressed, and 44% were extremely stressed. This leads me to my third and final point, which is that we need to prioritize funding mental health interventions in adolescent and young people programming. This includes providing much greater financial support to community-based, peer-led psychosocial support groups. Looking at all the people who have lived with HIV for more than 20 years, they continuously inform us that they overcame their mental health disorders through the support they got from these groups, which are a lifeline for so many people. In the current situation, especially for Kenya, where there is no funding for this, it has left a lot of young people with nowhere to turn to. It is high time we take action to ensure young people living with HIV and affected by HIV are healthy, and not just physically, but also mentally. Governments, development partners, and young people need to work together to ensure that we have an effective mental health response that meets the young people's needs. Therefore, we must invest in research and collection of data relating to mental health. Number 2 is to use already available systems, both in the community and in health facilities, to enable the prompt assessment and referral of young people facing mental health challenges. Thirdly, is to ensure training of healthcare providers to equip them to deal with mental health challenges facing adolescents and young people. And finally, we have to properly fund strategies to mitigate mental health in AYP programming. Let me just close by saying, there is no mental health. There is no health without mental health. Thank you.
Thank you so much, Cindy. Cindy, if we were together in a room, we would be clapping for you. And it would be an enormous clap. Because thank you very much for the presentation. Thank you for sharing, and thank you for also your openness. Because one of the things that you've shared is that, you know, when it comes to mental health, actually often people aren't open, right? And it makes
Yeah.
it even more difficult to be able to have some of these discussions because they're a little bit abstract. So the fact that you've been open and shared is really, it really matters. It's really, it's a really big deal. And it helps us to have a conversation about some of those real issues around anxiety, around depression, around self-harm. So thank you very much for sharing your personal experiences, but also your perspectives in terms of what we need and the points around needing data. So we really continue to understand what's going on, integration of mental health in existing services, and the point about community, funding communities, because ultimately people live in communities, right? We don't live in health facilities. So what is it that communities, how do we support communities to be able to take care of people as a whole person? And I loved how you ended it as well, that there's no health without mental health, like totally. And it's amazing that we're starting to recognize that. Yeah. Thank you so much. How did it feel to see yourself presenting? Is it a bit weird?
Yeah, it it felt a bit weird because I had to like relive every moment of it. Yeah.
Yeah. It's amazing. It was really amazing. And we've had some comments come in. Oh, others are clapping for you. Cindy told you. And also
Thank you.
and people saying that really, really excellent and very, very clear. So thank you so much, Cindy. So colleagues who are listening, please do type in questions, type in thoughts as we have the discussion. We're going to spend the next 20 minutes, Raphael, Cindy, and myself, having an initial conversation that is very much based on, Cindy's own personal experiences, but also just thoughts and perspectives in terms of young people, from a young person's perspective. What would we like to be seeing in this area? Then after that, we're going to have a break, and then we're going to hear three abstract presenters who are going to talk about specific interventions. So that's the plan, basically. So please do share any questions, any thoughts, and between Raphael and myself, we're going to bring them into this particular space. So Cindy, just to get us started, I just wanted, just to reflect on what you were saying about young people experiencing anxiety and depression and even trauma. Often what happens is that young people think, what's wrong with me? Like, what's wrong with me? Why am I, young people often take it on, right? Like it's their issue. But often it's not, I mean, it's not about their worth, it's about needing support. How do you think we should get young people quite early on to know that actually this isn't about them, like this isn't about their worth, it's about getting support? Mental health is, if you have a mental health problem or issue, you need support like you would if you
Yeah.
need to go and get your ARVs. How do we get young people to hear that message like early on?
Yeah, thank you very much, Georgina. So I think what is more important is that more young people should be able to open up, just like I have done. The more young people open up and dare to shed light about their journeys in mental health, then the more we get the message out there that yes, this can happen to anyone. This can happen to a young person who's below the age of 20, because most of the time when you are young, they ask you, why are you stressed, why are you depressed, because you don't have things to do exactly with your life apparently. But the more we as young people are able to come out and speak about the mental health journeys that we have had with ourselves, the ones who have overcome, the ones who are just experiencing mental health at the moment, if they are able to speak about it, then the more adolescents and young people will understand that there is really nothing wrong with them, and it is not about them. It is just that they need the support to overcome this. And how they get this support is basically by getting to know what other young people have gone through. If you are able to speak to a person who has gone through a certain journey, then you are able to see, so there's nothing really the problem with me. I am just going through this period and I can do ABCD to overcome this. Yeah.
Yeah. So it is, the starting point is being able to be able to be open about it, right? And to be able to
Yeah.
talk about it. But even that initial bit is really tricky, isn't it? Like
It
something
is.
something needs to spark in you. You need to be supported or encouraged or be in an environment which just allows it to come out, right?
Yeah. And so just to put it into perspective, the problem with mental health most of the time is because we lack like sort of indicators that will say this particular person at a certain health facility is experiencing mental health challenges. If you cannot be identified, if the health facility in which you are in cannot identify that you are going through something, then they are unable to provide support. So it is very challenging that you are you have the problem, and you have to find you are the only solution. You are the start of the solution. So you have to identify, first of all, you're experiencing something, and second of all, that you need to be there and open up to someone, first of all, about it, so that you can get the support and counseling, because otherwise you don't get that. Yeah. It is such a challenging journey, to be honest.
Yeah, but I think you've made a really important point there, right? So there's in terms of yourself kind of opening and sharing, but a provider can also kind of prompt, right? So if you're sitting in front of a provider who, you know, where you're having a discussion, depending on how they also lead that conversation and the prompts and how, you know, they could at least ask those kind of prompting questions that will open it up for you, right? That allow you to be able to ask those questions. Yeah. Raphael, are you seeing the many questions that are coming in? It's really like, Cindy, it's a good thing that we've got time to hear from you. So one of the first, Raphael, I'll take like 3, and maybe if you can also keep track of some of them. But maybe some of the initial ones. So Cindy, there's been several people really just really excited to hear from you, including one person saying that they wish you could come and speak to some of the adolescent girls and young women that they work with. So that's interesting, and I think it's an important thing to be able to do that peer to peer. So I think it's an important suggestion, you know, spaces for young people to be able to share. But there's a question around, have you seen any examples of successful programs? So in Kenya, have you seen any examples where like mental health has been well integrated into existing HIV services or health services?
So specifically for Kenya, no, I haven't seen any programs yet. Maybe they are, but I don't know about them. But in some countries, I think South Africa probably, in South Africa, there are especially partner-supported programs. There are lots of young people who get mental health support through like psychosocial support groups, and they can be able to open up and talk about the challenges and problems, such as things they're just going through in general life that may affect them mentally. But what we exactly need, I think, are those indicators. Like if I go into a certain health facility, and I am not sure of what I am experiencing, be it depression, especially depression, it gets a little bit tough, because we'll just say you are maybe lazy or something like that, and you don't want to be yourself, or you're just acting out, especially for teenagers. But we need like to go to mental health facilities, and the healthcare providers need to be open and just have indicators that will lead you on. These indicators are very important to be developed, because once they are in place, you can be able to, a healthcare provider can be able to gauge what exactly is this person experiencing and refer them to the correct mental health experts, be it a counselor or someone just to talk to, or just even a peer who can manage and restart the conversations and help you overcome those challenges. But the problem is we lack, in Kenya, I have not seen the programs yet.
Well, it may be later on when our abstract presenters speak, we might hear of some really good examples where we've started to see those connections being made between mental health and HIV in service delivery. But I think it's an important point that you've made in terms of, from the provider's perspective, there are a range of different issues that they need to think about and consider. And we need to make sure that mental health is critical, that it's part of that, right? And that they know what it is that they need to be asking, to be looking out for. They need to understand what can they manage and what is it that they need to be able to refer a young person, to services to be able to get the care that they need. So there's work that needs to be done with providers, absolutely. And it would be great to hear from participants if they have any other ideas. There's another interesting question, Cindy, about mental health. We know that it's very stigmatized, and are there ways you can think of to reduce stigma around mental health? So you talked about young people speaking up and being open. Are there other ways of reducing stigma?
No, I wouldn't say that there are many ways to make the stigma easier for young people who are facing mental health. But I will say creating a conversation around mental health, because most of the time we just like to say, yeah, people experience depression, but what exactly is depression? So how do I know that my little niece in my house is experiencing depression and is not just acting out, as people will say? So I think there is need for a lot of sensitization when it comes to mental health, because it is such a broad range, and some people just experience something small and will say, oh, I'm experiencing this and this and this. But for some of us, we just sit and think there is something wrong with us, because we are not our normal selves, and we keep on wondering, then what did we do wrong? Why are we like this? So I feel like there needs to be a lot of sensitization around mental health, especially within the communities that we live in, so that people are able to say that this person is actually facing this and this, and not just assume that you are acting out or you're just being a bad adolescent, especially for adolescents, because that happens a lot. Yeah.
Absolutely. And maybe those kinds of films, like the one that we watched with Tuka, where we're understanding what is the difference between anxiety versus depression versus, having this fear and worry. What is it that drives us to suicide? Like, it's understanding those the same way as we understand when we have a headache and a toothache. It's really understanding that better, which we all need to do much better, and be able to appreciate that in other people as well. Absolutely. Raphael, would you like to, are there a couple of questions that you would like to share with Cindy? Cindy, are you doing okay? It's not
yeah.
Okay,
No,
Raphael.
I am okay.
Yeah.
Yeah. So Cindy, like when you say that young people can turn out to their peers, their fellow young people, for advice or for mental health support. But do you think that young people are really equipped with that knowledge or ability to support their peers, their fellow young people? Because they are the ones who will receive these complaints from the fellow young people. But are we equipped well to provide support to fellow young people?
As a young person, from a young person's perspective, I would say definitely not. There are some things I can handle, but there are a lot of things that I can't handle. If you come to me with a problem, with a mental health problem concerning treatment and such kind, I am definitely able to help. But if you come to me with facing depression or anxiety because of your parents or certain things in school, I am completely unable to help you, because I just know what I experienced, and that is like 80% of the knowledge that I can share with you. So I will definitely say no, young people do not have the right capacity to do that. However,
and do you think there is something
with
okay, go ahead.
However, with with community sensitization on mental health, just like the one that was shared before, yes, I believe that we could be capacitated enough to handle some situations, and definitely refer others to healthcare providers within our systems who can be able to help. Yeah.
So we see it's not an individual role, it's a societal role. We all come together to help each other in this. We as young people have a role, parents, caregivers, and society at all.
Exactly.
I know you've mentioned a number of efforts that should be placed to support these parents, caregivers, society, so that they can be better placed to support young people with mental health. I'm also seeing a question here. A question saying that most individuals are not willing to open up about what they are going through, and all we have is the idea that of what they might be going through. Now, how can we help them in terms of mental health? Those who are not able to open up. I know it's a critical thing, and it's not always simple to speak out about mental health. But what do you think will make the situation ease for young people to open up?
So yes, I agree that it's very hard for people to open up, mainly because of the judgment they get right after they open up. So the best way to go about it, I would say, is to give these people time. Whenever people are ready to speak, and when it is too much, they will speak actually about it. But sometimes they need that extra support from a parent, from a healthcare provider, from another peer, just to be open about it, because you don't want to open up and feel weird about it right after.
Yeah.
So one of the main things I will say is that we need first to get some more and more young people opening up, because if people can relate and say, Cindy could go through this, and then there's nothing wrong if I go through this. So I can open up, maybe I can open up just a little bit and see how far it goes.
Yeah.
And then it will be easier for them to like continuously open up little bits until we can find them the solutions to what they are experiencing. Yeah, but I agree, it's a lot. It took me 8 months, so it shouldn't be easy.
Okay.
Well, yes, back to, yeah, well, thank you for sharing that, Cindy. And I think a couple of the questions that we have seen are indeed about the support system. So, you spoke about having some peer support and support groups. So there's definitely a role for peers, right? To
Yeah.
some extent. And if peers are also supported to be able to ask the right questions, to be able to provide that kind of some basic counseling. Like there's a lot to be said for that kind of work. And I think we will be hearing about later about some interventions which are peer-led that support in terms of mental health, where peers are capacitated to be able to do that work. So there's support groups, which has the peer-to-peer interaction, and you've just spoken about the role of parents. So could you speak a little bit more, the question about the role of parents in really contributing to positive mental health?
So parents, I think, are the biggest players in this, because most of the adolescents and young people that I work with or I have interacted with basically live with a parent or a guardian or someone in their families. So they are supposed to be the first people to identify that their young people are not okay. They are also the first people that should try to get their young people to open up. But the question is, does that really happen ideally? Because most parents, especially in Kenya, are so caught up in chasing on how to feed the babies and feed their families and take care of them. And they don't really notice when you start thinking into such as depression, or when you start facing anxiety. And also the way your parents raise you up speaks a lot on how you will tackle your mental health. So in a family where you are raised and you don't speak about anything, then you will never speak about the challenges you face. But in a family that is more open and you are able to speak about anything at any one period when you face it, then it becomes easier for you to open up and say to your, or even to your sister or a sibling, and say, hey, I'm not feeling well because since I started taking this and this, I'm not feeling well. I don't feel like taking a shower. I feel like I've lost hope in life. You are able to open up essentially. But when you are in a family that doesn't talk about anything at all, then it becomes really hard for you to even open up, even just to your friends, not only your family, but even your friends and healthcare providers. Yeah.
Thank you. So in short, parents could be the biggest influencers,
Exactly.
but it kind of depends on what their attitudes are, right? And how they approach the subject and many other subjects. We often talk about this when it comes to esta racha as well, and conversations, that parents have around sex or not, So I understand that. And I think that there are a number of programs that work with parents, right? To have like community dialogues with parents, to be able to support parents, to be able to have those conversations with their children, which doesn't come easy in all contexts.
True.
So that's important. So Cindy, I'm blown away. Raphael, are you blown away with the number of questions for Cindy?
Yeah, so many questions coming in. I think it's because it's an interesting thing, and everyone has an experience with this and wants to learn more. Yeah.
Exactly. And we will have in the second part of this session, we will hear from 3 other abstract presenters who will talk about different kinds of interventions. So I think that we will come back to these questions, and feel free to ask these questions again. But I think I will just maybe pick out another set, and Raphael, you do the same. And Cindy, if you're still happy to keep going before the break. Yeah? Okay.
Yeah.
Well, there's a set of questions around research. You talked a lot about data. So it's one of the things I'm left with this session, knowing that Cindy loves data. So there's a question about what kind of data or indicators you feel are most important to have and why. But also, I'm going to add a second piece to this question, which is a question from someone who said, yeah, it is important to have data. And they're asking, how do we involve young people in kind of research and the design, the implementation of research around this particular topic? So it's kind of twofold. What kind of data, when you say it's important to have data around mental health as it relates to adolescents living with HIV, like what kind of data? And then separately, how do we involve young people in gathering this data?
So that's a long question, but I'll try my best. So I wouldn't say that I have all the information on what kind of data, but for me specifically at the moment, I would need to know the extent, especially in Kenya, in Africa. If you look at the data online, the only thing that speaks about mental health as at now is the rate of suicide happening among young people. But that is not reflective of how many young people exactly are facing anxiety, how many people face depression, how many different forms of mental health. It's not just suicide. Suicide is sort of like the action that follows after mental health has not been addressed. So we need just first to know the extent of mental health challenges within our countries, because then we can start advocating for sort of resources and government uptake to ensure that we know that at a certain time when they are prioritizing health for their budgets, then they have to include mental health as part of it. When they are creating solutions within health, that mental health is part of their discussions. But at the moment, because we do not know to what extent are young people only facing mental health issues, we don't know. Personally, I looked for that data for a very long period of time, and it was very hard to find because we don't know at all. So I feel like right now we just need the extent of and the segregation according to the types of mental health that we know, and then that will help us program, even apart from like advocacy, it will help us program that we know there are 700 young people in Nairobi only who are facing mental health. These young people are based at certain locations. Then we can go and put in interventions that are in those places to enable us reach out to them and just start the conversation on mental health and see challenges that not challenges, interventions and solutions that will help them come out and speak about it openly and even better their lives while at it. Yeah.
Have someone. So Georgina, you picked up my question. I was also about to ask that question on that, but because we have so many of them, and also Cindy, you talked about the need for support systems to help young people with their mental health. Do you think as young people we can come up with innovative suggestions of the support systems that can be put in place to support young people who are facing mental health difficulties? You know, this is not a priority in most African countries. It's not likely to go to a place to find a mental health supporter and things like those. What are the things that you think as young people can recommend to public servants that innovative ideas that we can come up with so young people can be reached out with this mental health support?
So it depends. I feel like it depends with the level or where you are at with your mental health journey. If you have already accepted and acknowledged, then that becomes easier, and we can program for things like group therapy sessions. We can program for art therapy sessions and the psychosocial support groups, just to enable you to start talking about it. So if you know that you are experiencing mental health, then that's easier. There are a lot of interventions that we can put in place. But the problem starts with if you don't know in the first place. So if you don't know what kind of, if you're experiencing mental health, then we need interventions, first of all, to help you identify that you are going through a mental health challenge. And from then on, we can put in the right interventions for you to be able to get well.
That's very well said. I think it always begins with you when you are in the right situation to recognize that you need help. That's the best beginning to get the support from other people. So we're going to have a break, just a minute now, so that we can come back and hear from our host presenters. And we have three of them. We'll be hearing one after the other. Then we'll open up for the panel discussion later on. So before we go to the break, Cindy, do you have anything that you want to say as a final word? I know you can also come back later on during the panel discussion, but if there is anything that you want to say from all these questions that you have received and from your experience with today, Karibu.
No final. Half of all of these people.
Oh yeah, sure.
There you go.
Well done.
Thank you very much, Cindy.
Thank you
for doing the presentation, the keynote for us, for sharing on this very complex topic. So thank you very much, and for really kind of very clearly articulating some of the issues that young people go through. Your thoughts around some of the things that work in supporting young people, but also some of the collective challenges that we all need to be aware of, right? As we try to do programming and support young people and their parents and others around this particular issue. So yeah, so Raphael, we're going to have a break now for 10 minutes, everybody. So enjoy your coffee, your tea, but don't make it long, because we are really going to start back sharp on time in 10 minutes. So for many people, it's 2 o'clock in the world, but since everyone's from everywhere, just in 10 minutes, we will start back. And as Raphael said, we'll hear from our abstract presenters, and then we can ask more questions and so on. So 2 o'clock sharp Southern African time. So yeah, all right, bye. Enjoy, come back.
I'm gonna be free, 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 free from everything around me, free from everything.
Welcome back to our session 6 of HIV and Adolescence workshop. I hope you had a great break, and we're back again to wonderful sessions. And now we're going to head to abstract presenters. We're going to have 3 of them, but we're going to welcome one after the other, and then we're going to have a chance to ask them questions. So our first abstract presenter today is Miss Nicola Willis from Zimbabwe, and her abstract is about effect of peer-led mental health interventions on virological suppression and mental health among adolescents living with HIV in Zimbabwe. So the abstract is effects of peer-led mental health interventions on virological suppression and mental health among adolescents living with HIV in Zimbabwe. So ladies and gentlemen, let's welcome Ms. Nicola Willis.
Thank you for the introductions, and hello to you all. I'm presenting a collaborative research study involving Zimbabwe's Ministry of Health and Childcare, local partners, international research institutions, and it was funded by CIF. Adolescents living with HIV experience a high burden of mental health disorder. This is associated with poor adherence to ART. The CATS program in Zimbabwe has been found to improve adherence, viral suppression, and psychological well-being among adolescents living with HIV. Meanwhile, also in Zimbabwe, the Friendship Bench model has found that grandmothers trained to deliver problem-solving therapy, or PST, are effective at treating depression in adults. We hypothesized that by combining CATS and the Friendship Bench, we could improve both mental health and virological suppression among adolescents living with HIV with poor mental health. We conducted a 12-month trial to measure this in 10 districts of Zimbabwe. We randomized 60 clinics, 30 to the control arm and 30 to the intervention arm. The control arm provided CATS counseling services as usual, but in the intervention arm, the CATS had additional training in PST from the Friendship Bench. We enrolled 14 adolescents living with HIV in each clinic who had symptoms of a common mental disorder. We screened a large number of adolescents living with HIV and excluded those who had fewer than 7 symptoms of a common mental disorder using the Shona symptom questionnaire. We excluded a few others who couldn't participate. So in total, we had 421 adolescents at intervention clinics and 421 at control clinics. Follow-up was really good at 91%. Of note, at baseline, almost 40% of adolescents living with HIV screened positive for a common mental disorder. The primary outcome for this study was virological suppression, defined as less than 1,000 copies, and we assumed participants that died were virologically non-suppressed. Sadly, 3 participants did pass away during the trial. The secondary outcomes were the proportion of adolescents with 8 or more symptoms of a common mental disorder on the SSQ. We also looked at depression using the PHQ questionnaire, quality of life, and then we also looked at the severity of symptoms. Viral suppression improved equally in both arms. Where we had standard CAT support, the proportion with viral suppression improved from 66 to 88%. Where CATS had additional training in PST, viral suppression improved from 63 to 85%. So there was no additional benefit on viral suppression from additional training for CATS in PST. Both arms also showed improvements in mental health, but there was a greater improvement in the control arm where CATS had additional training. Almost everyone had 8 or more symptoms at baseline, but after a year, only 2.4% of the intervention group still had 8 or more symptoms of CMD. In the control group, it was 10%. So there's strong evidence that enhanced counselling from CATS led to improvements in CMD. This was the same for all the secondary outcomes for depression, quality of life, and for severity of symptoms. We also wanted to understand the CATS experience of delivering PST, so we also collected qualitative data throughout the trial. This included transcripts of CATS sessions with their clients, case reviews with CATS mentors, CATS audio diaries, and we conducted 2 FGDs at the end of the trial. PST was difficult for young people to implement, and from the CATS perspective, it was also difficult for their clients. However, we found that CATS adapted it to better fit young people's needs, and the adapted version worked relatively well. So what we're measuring here is a slightly adapted version. As we found in other studies, adolescence problems tended to be very relational, such as bereavement, abuse, or financial problems. And these are inextricably connected to someone else. And young people often have a very limited control and agency to resolve these types of complex problems and rely on others to help them. This is somewhat different to adults, where the model was originally designed for. So the emphasis on the solution aspect of problem-solving therapy, if they didn't have further support to achieve this, could at times be intimidating. Further, both CATS and young people they supported really wanted to get it right. So this was another reason that they found the emphasis on solutions to be challenging. So what worked well for adolescents in CATS? We found that the nature of the intervention created a space and opportunity for young people to talk about problems, and this was really valued. This involved a broader conversation, moving away from HIV and treatment to what was actually going on in their lives. CATS were really well placed to provide this trusted and empathetic support. In talking about their problem, adolescents found that their problems and experiences were both recognized and validated. So what we found was really happening was problem discussion therapy, in which even talking about the problem had enormous benefits, even if it couldn't be resolved without additional support. How can it be adapted? Well, it's particularly important to involve significant others in the adaptation, including caregivers and professionals. The quote on the left illustrates where the problem is often related to a parent. The CATS said, challenges encountered by the beneficiary are beyond their ability to mention or answer to without a parent being present. The parent is the one whom we need to talk to before talking to the child so that we can help the child. CATS are well placed to take on this mental health role because they have often experienced something similar, but this can make them vulnerable too. As illustrated on the right from one CATS, who said, when discussing with them about their problems, it is difficult at times, but as a CATS, I am not supposed to be overwhelmed by it, as I am supposed to help the beneficiaries. We need to invest in support, otherwise we can make CATS or other peer supporters vulnerable and at risk as they take on these roles. What could this support look like? We've come up with this framework for supporting peers to deliver mental health interventions and hope to publish this soon. But key aspects are training, referral pathways, being very clear on the remit of their role, supervision and mentorship, and a recognition that talking helps, even if it is beyond the capacity of young people to solve the problem. In conclusion, we found that viral suppression was improved in both arms, and there was no additional benefit from adding in the more formal PST counselling approach. This confirms that CATS, who are already trained and mentored as peer counsellors, improved viral suppression among adolescents living with HIV, including those with poor mental health. We acknowledge still more needs to be done for the remaining 13% who remained with high viral loads, possibly due to continued adherence challenges or possible drug resistance. Both CATS and the CATS Plus enhanced counselling intervention resulted in improved mental health, but there was, however, a greater benefit where there was enhanced counselling. While we can't attribute this to PST as described, the adaptive problem discussion therapy which CATS actually delivered highlights the need to recognise and invest in the critical role which young lay counsellors have to play in both the mental health and HIV response for adolescents. Thank you so much.
Thank you so much, Nicola. How did you feel seeing yourself on the screen? Oh, I can't hear you because you're on mute. I'm sure you said you felt great.
No, I said I felt awful and I still haven't learnt the mute button. Anyway, thanks.
Thank you so much, Nicola. We really, really appreciated hearing from you. And, you know, in the first half, you know, people were sort of asking, we had participants asking about, you know, are there any kinds of like interventions that are quite inspiring or any techniques? And what we've heard here is about a peer support program. So the CATS model. So Sam Jackson asked, and you responded, Nicola, so that's Community Adolescent Treatment Supporters. So these are young people who are living with HIV and are supporting their peers. to be able to take their medication to stay healthy, including their mental health, their psychosocial support. And also the other technique, of course, that was shared here is PST, right? Problem solving therapy. So thank you very much for sharing. I have to say, I was very struck at the beginning when you said that amongst the young people who had been screened, almost 40% had some sort of mental health condition. So that really goes to highlight the need, isn't it, amongst this group?
Absolutely, Georgina. I mean, I think that was very much a driver for this trial. We did a study a few years back, which found up to 60% of young people were at risk of poor mental health, and that correlated with poor adherence. So we wanted to revisit that. We have done work that confirmed that peers, these CATs, peer supporters, if trained and mentored, can improve viral suppression, but we didn't, it wasn't for all. I think we got to sort of 88% that were virally suppressed. We do know that mental health conditions have such a role to play in adherence. So we thought, well, if we could combine the friendship bench model of problem-solving therapy, so a more formal approach to that's evidence-based in terms of treating depression, could we try and close that gap in terms of viral suppression, but also improving quality of life for young people? But the figures are incredibly alarming, and we want to, so here in Zimbabwe, we're advocating hard, trying, as Cindy said, we can't advocate, we can't change policy, we can't change programming if we don't have these numbers. And so we're really hoping that this helps to try and shape people's awareness.
Yeah. And Nika, did I miss it? Tell me about the bench aspect. Did you actually, is there any bench? Did that actually come up? Did I miss that?
No, so the friendship bench, traditionally, it is, well, not, they're doing it now, it's all over the country. In other countries, it is literally a bench. So normally in the traditional model of friendship bench, they train grandmothers who sit on a bench at the clinic. The CATs opted not to, because they didn't want to be so visible as young people living with HIV. They wanted to continue their role in the facility, being very available and accessible as peers, but not to be out there. And young people said it as well, they preferred not. So that was an adaptation that we worked on.
Adaptation. Okay, so it's metaphorically speaking. I thought I would just get that out there in case anyone is wondering about the actual benches. Yes, so it's an adaptation. Yeah. And I mean, so everyone who's listening, do feel free to send in questions. You could send in questions now, or after we hear from the three abstract presenters, we'll also have a discussion where the different abstract presenters, and Cindy will join again, can also respond to questions. So otherwise, I will just keep asking Nicola questions. So, we have one from Chris, who says, are CATs trained in counseling or coaching skills to be more effective peer supporters?
Thanks, Chris. So we've been doing this since 2009 with the Ministry of Health. We adapted the counselling training that adult counsellors get in the ministry. So they are trained in counselling tech skills and techniques, and this is a huge part of our ongoing capacity strengthening, supportive supervision for CATs. So yes, they're trained as peer counsellors. And I think that's one of the things about this trial. There was quite, they were already counselling. What we were testing was if we add in an evidence-based, more formal approach to their counselling, would this make any difference? And I think that's why I think our interpretation is that where you see when you look at the results in the different arms, is that CATs in the control arm are probably continuing to counsel around adherence. Yes, they touch on issues affecting adherence, but probably in the intervention arm, there's a broader approach to counselling young people about all sorts of problems that they're experiencing, which probably is maybe what led to the improved mental health. But both arms showed that peers, if trained and mentored fully, and we can speak a lot about the systems issue, which Cindy and others were raising, because I think that's key, and that came up in the slides. If trained and supported to do this, and they're highly effective at both supporting suppression and mental health.
Yeah, excellent. And so for those asking about interventions that have been proven to work, I mean, this is an example where there's something in place already where peers are trained, supported to be able to help, you know, their peers, but we've basically added another component that gives them better skills to be able to also assist with this particular aspect around mental health. Yeah, yeah. And tell me, Nicola, in terms of, it hasn't come up yet, but this issue of maybe boys versus girls and or young men versus young women in relation to mental health and support and peer support and problem solving therapy. Is there, have you noticed any differences? Is there anything that as programmers or advocates, like, we need to be aware of when we think of, like, from a gendered perspective?
Yeah, I mean, quantitatively, the results of this trial didn't find any difference between the boys and the girls. I will emphasize that the boys were more likely to have virological failure at baseline. And I think that's a big shout out for the boys in terms of interventions as well. We did find that both males and females equally reported and experienced, and this is the same in our program data as well, equally experienced stigma, poor treatment at home, inadequate support, fears and worries about their relationship, about their future. And what we do find, though, perhaps, and I'm being cautious because this is anecdotal, but well, certainly in the trial, males are more likely to report substance abuse, and we see that programmatically. But I think this is an area that needs a lot more investigation. Again, programmatically, we find males finding it more challenging to come forward with their experiences. We certainly screen more girls because they're coming forward more as being at risk. So definitely, I think it's an area for more exploration.
Okay. All right. Thank you. Thank you very much for sharing. So, Nicola, we're going to leave it there for now, and I'm going to hand it back to Raphael to introduce the next abstract presenter. But thank you so much. Really appreciate it. And speak in a second.
Yeah, thank you so much, Nicola, for the very wonderful presentation and informative. And thank you all who are sending questions. You can see questions and we're going to get to them during the panel discussion. So as I welcome the next abstract presenter, also keep in mind that as we listen, let's keep on noting down questions and write on the chat box. And after we hear from her, we can also take these questions to her so that we can hear the responses. So our next abstract presenter today is Miss Monica Kamkwema from South Africa with an abstract titled Mental Health and Substance Use in Adolescents and Youth Living with HIV in a Context of Violence. So let's welcome Miss Monica Kamkwema. Karibu sana.
Thank you, everyone. My name is Monica Kamkwema. I'm a PhD candidate at the University of Cape Town. And the title of my oral today is Mental Health and Substance Use in Adolescents and Youth Living with HIV in a Context of Violence. So just a brief background. We know that people living with HIV, and more particularly adolescents and youth living with HIV, face an elevated risk for mental health disorders. This is both due to sometimes the effects of antiretroviral treatment, but also just general psychosocial challenges associated with living with a highly stigmatized communicable condition. So if we have a context of community violence, which is prone to trigger mental health disorders in people, this further increases their vulnerability towards mental health disorders. In looking at the context of Cape Town, which is the background and the context within which this research was conducted, it's a very volatile setting. So a lot of the settings in which the participants in this study live are peri-urban settings on the outskirts of the city, which are prone to gang violence, substance use, and a lot of absent parenting. In fact, Cape Town is one of the world's most dangerous cities in the world, surpassed only by certain cities in Latin America. 2018, the police recorded more than 2,800 murders and a homicide rate of 66 killings per 100,000, which triggered the government and the national government to send the army into these township settings in order to mediate the community violence. So the aim for this study was to investigate depressive symptomology and psychological distress, as well as substance use among adolescents and youth living with HIV between the ages of 15 to 24, living in these so-called townships in Cape Town. So some preliminary results. We had a sample of 92 adolescents and youth, of which 3 out of 4 were female. For 27% of them were neither in education, employment, or training, defined as NEET in an economic definition, and 44% were multidimensionally poor, meaning that they were deprived in more than a third of the dimensions necessary for good health and functioning and economic sustainability. 70% of the adolescents reported household food insecurity, of which 38% experienced severe food insecurity. That is, having to cut back on meals in a day or not having enough resources to actually buy food in their household. In terms of parenting, 58% reported being orphans, having either lost one parent, and 12% of them were actually double orphans who had lost both parents. Less than half reported a biological parent as a primary caregiver. In spite of this, we did find a high level of positive parenting, or they self-reported a high level of positive parenting using the Alabama Parenting Questionnaire. And there were low scores on poor supervision, meaning that they did report that their parents would ask about their whereabouts or the kind of their friends that they hang out with, and they would enforce certain curfews. Parents being a proxy for caregiver, which would either be a biological parent or an extended family member like a grandparent. We used the internalized and enacted stigma scale devised by the HIV Stigma Scale Group for adolescents living with HIV, and more than 2/3 had experienced some level of stigma within the past year. So our main outcome of interest, which was depression, was measured using the Center for Epidemiological Studies depression scale, of which significantly more females reported depressive symptoms compared to males, 51% and 19% of males. But looking at more generalized psychological distress using the Kessler Psychological Distress Scale, we found no differences by gender. And we found that 44% reported experiencing some level of psychological distress within the past month. Alcohol use, and particularly harmful use of alcohol, was also quite prevalent. So 41% reported having consumed alcohol in the past month, of which more males reported frequent alcohol consumption compared to females. And 24% of our overall sample reported having binged on alcohol, meaning that they drank 5 or more drinks in succession within one sitting in the previous month. 48% of males were current smokers, consuming, using tobacco or tobaccoless products in the past month, and 25% of females, significantly less females, were current smokers compared to males. In terms of substance use, the lifetime prevalence of cannabis, illegal drugs, and other substances ranged from 27% for cannabis, 7% for methamphetamine, known as stick, cocaine or mandrakes, so that is for hard drugs, and more prevalence of inhalants, so using glue or sniff or inhalers to get high, so 10% of that, and then 15% reported having used over-the-counter or prescription drugs for purposes other than they were prescribed for. Overall, lifetime use of any illicit substance range was 53% for males and 30% for females, so significantly higher for male youth living with HIV compared to females. Violence was highly endemic in this setting, as we expected, 84% reported moderate to high exposure to community violence. That is, they either witnessed or had heard of a killing in their community, or they had seen someone pointing or shooting a gun at someone other than the police. And so in conclusion, we found high levels of depressive symptoms and distress in these urban youth living with HIV. There was some level of parental supervision, but not adequate. So there was poor parental monitoring, despite them reporting, because their actions actually spoke to the opposite. So having a non-biological parent as a caregiver, we actually saw that they were more prone to risk-taking. Data not shown here. So how do we deal in the context of violent communities which are, where substance use is prolific and where youth are left to their own devices most of the time? So all of this can actually modify the pathway towards mental health problems in an already vulnerable population. How do we build resilience and healthy coping mechanisms? So some suggestions are via monitoring of social activities, either by parents or other community members who can step in as proxy enforcers of informal social control, and possibly providing recreational options in order to interrupt harmful pathways that predispose youth towards engaging in harmful behaviors. So in conclusion, also, I'd like to acknowledge my co-authors, Dr. Blessings Gauzi and Dr. Tolu Oni, who are very instrumental in carrying out this research. And mostly thank you to the adolescents and youth who agreed to take part in this research, sometimes sharing highly sensitive and triggering information with us. And we'd like also to thank the City of Cape Town and the Western Cape Department of Health, who facilitated access to these participants. Funding was secured from the Bristol Myers Squibb Foundation Secure the Future grant, as well as the NRF and the German Academic Exchange Services. And these are my contacts if anyone is interested in further information or collaboration. And we just also like to thank the School of Public Health at the University of Cape Town and our health association in Namibia, which was a partner organization for this research. Although unfortunately we couldn't replicate the same study in a different context for comparison. Thank you.
Thank you so much, Monica. Thank you.
Thank you.
How did you feel seeing yourself? That was a great presentation.
Thank you. I had a different hairstyle, so I felt a bit dissociated. Yeah, but otherwise, yes, I was quite impressed with myself.
Good. No, it was a very clear presentation, and I mean, it's amazing as we try to understand this area a bit more, as we try to just sort of dive deeper into sort of mental health and adolescents living with HIV. It's great that there are PhD students like yourself that are looking at specific areas, because we need more, as Cindy said, right? We need more understanding and learning and depth in certain areas. So this additional dimension around substance use is really interesting. And I mean, when we had the discussion with Nicola, I asked the question about, you know, young men, young women, and Nicola mentioned the point around substance use, right? And young men. And I think your data is showing more substance use amongst young men, and there's a correlation there in terms of mental health. I don't know, do you want to speak a little bit more to that gendered aspect and what that means in terms of interventions that are supporting young people, you know, differently, right? Because we can't see young people as a homogeneous group. We need to think, how are things affecting young people differently?
Yes, definitely. Thank you, Georgina, for the question. So in general, like the mental health literature does show, like in teenage girls, there's earlier risk, or not risk, there's earlier outcome of depression. So they will be able maybe to internalize feelings more and express them more. Whereas we'll find higher suicidality and risk-taking in young men. This is in the general mental health literature. So they would be more prone to suicide or to risk-taking behaviors earlier compared to females, but then after the age of 40, it kind of actually comes to the same. So one of the hypotheses is that young men aren't able to express, so then they would try and express by way of action or by doing things. And it's actually well founded in the literature that young women have higher symptoms of depression and anxiety, but after a certain age, it actually equalizes out. So I think in this sense, if we look at a context of, for example, a young woman who would be approaching the health facilities more often. So like I found in my study, 3/4 of the participants were female. So they would be used to actually coming to a clinic and maybe more used to vocalizing, as opposed to a young man who might be in denial of his HIV status and disappear from the care system, and then maybe only show up later when he's sick. So in terms of this, I think it's about also asking about risk behaviors and asking about, because when we use the psychological distress scale, which is more general, so that would also ask them about, would it also ask them about being exposed to certain experiences. So they'd be able to identify that more, as opposed to vocalizing that I felt scared or I felt this certain way. So that more generally was kind of equal. So in my research, I've actually come to kind of a realization that it's about framing the right questions. So for example, a young man might not respond as positively to being asked, did you cry yourself to sleep, or something like that. Whereas a young woman might feel more prone to say, oh yes, actually I do. So it's very much about how do you tease out, and a lot of the instruments that we have aren't context specific, and they aren't actually developed to accommodate for that. So that's just one important point to note.
Yeah. And Irene asks the question, why does depression affect women more than men?
So I would say it's more diagnosed in women, which is what I was trying to say earlier. So young women can vocalize that probably better. So then the tools that we have would be more sensitive, like they pick up on that better in young women and be less specific for young men. So meaning that they fail to diagnose those who actually have in young men, because they probably aren't tailored enough to accommodate. Because then I think ultimately it would possibly be the same. So it might be a confounding in terms of the tools that we use and in the framing and the language that we use.
Yeah, absolutely. And we have a number of questions from Crispin, and this speaks also to when Cindy was speaking, there were a number of questions around stigma and internalized stigma. So Crispin asks about, can you manage mental health issues on your own? And what are some of the programs that can help you kind of address the issue of mental health and stigma? But and he actually brings in a point around faith and maybe spirituality. So I wondered whether that cluster just around stigma, internalized stigma, mental health, I don't know whether you would like to just speak to this bunch of issues.
Okay, so just a disclaimer, I'm not a qualified mental health professional by any means, but having been someone who's also struggles with mental health and who's been in therapy for 5 years now, I would say like a mental health diagnosis requires a lot of support, be that from family or in contexts where maybe you don't have a parent or you don't have a close family. It could be from a caregiver of being a healthcare provider, or a mental health professional, which I know are not as easy to access in our settings. But I'd struggle to say that you can deal with it on your own. Like, I wouldn't advise that. Yeah, because it does take a community and a concerted effort. So something like a faith organization could actually come in. Like, we probably all have a pastor, or we belong to some religious organization or so. So there's the concept of social capital and supportive networks. So those play a big role in like mental health generally. And being able to access like a supportive network that actually gives you positive reinforcement, that can definitely make a very big difference. It doesn't have to be a psychiatrist or a clinical psychologist or what. So even peer networks, although I liked what Cindy mentioned in terms of she wouldn't advise peers necessarily in terms of just someone who in your peer network, not necessarily someone living with HIV or whatever, because sometimes you don't all have the internal resources developed yet as adolescents. So it could be maybe you could talk to, I know with the cats, they're specifically trained to intervene Yeah, but like just like a normal adolescence, like because a lot of peer influence can be more kind of trying to be in a circle of peer pressure and what is perceived as cool and so on. Yeah, so I would think rather approach maybe an adult that you trust. So in my setting, for example, where there's absent parenting and a lot of the adults are actually themselves using substances, and that is what so adolescents and youth see this and they think that's like normal. So in this context, for example, there are community-based organizations that are trying to bring in positive role models, so like sports, recreational options, and so forth. I think I lost track of the question. I don't know if I answered.
Yeah, you've answered it really well, because it's basically about the support system. And this came up, there were questions around that in when Cindy spoke, right? People were saying, what is the broader social like support system? And that of course depends on the individual, where they live, their individual situation, in terms of parents being there or not, if they are there, how they are, you know, the health providers, what they're like, right? So I think that what you're doing is you're laying out the different actors that are part of that social support system. And I think a key message is around a trusted adult, you know, who might have a bit more life experience and be able to engage in these kinds of issues and listen to you, right? I think that that's the added bit. And just before we move on to the next presenter, Irene has asked 2 questions, but I want to kind of try to pull it into one. And it's about options for people who are mentally unwell in hard to reach areas, what treatment options. But later, Irene asked about antidepressants. And so I don't know, something around sort of antidepressants and availability of treatment options for people who might be depressed or who are depressed, and any interactions with HIV drugs. Did anything like that come up in your study or not?
Yeah, so I actually forgot to mention, or I didn't present it. So from the 44% who actually were showing depressive symptomology, only 11% had been previously diagnosed, like medically, clinically, when I went back to look in their folders. And then of those, I'm not quite sure the percentage who were on any medication, but I think in young people, medication should be like an end stage kind of solution, like SSRIs and so forth. So it would rather first initially start with counseling or CBT, cognitive behavioral therapy, or other kind of talk therapies or occupational therapies to try and just actually start with a less of a pharmacological intervention. Because I'm not too sure, I don't have data on interactions between SSRIs or antipsychotics with HIV medication. Unfortunately, I don't have that data, and it was beyond the scope of my research. But definitely, so some of them had been previously diagnosed, but 11% only, which is actually worrying. Yeah, and then of those, some of them were then they had been referred to other referral pathways, being either a social worker at the facility or an external psychologist. Yeah, but this was obviously in a context where there was a very supportive environment. So they were in a youth support group, and they could be followed through to check if they were going for their appointments and so forth. In a less in a more remote kind of setting where there's maybe less access to regular consultations and so forth, something like maybe even just like a chat group could work. Yeah, like maybe just someone saying, hey, I don't feel fine today on your phone, and someone responds. Yeah, because it's sometimes just a matter of asking how you are. And actually, sorry, just to speak on that again, there were some colleagues, like I think Prof. Willett and Dr. Kluwer did some research in Johannesburg where they said something as simple as a healthcare provider in routine HIV care asking about your future aspirations could be a way of identifying youth at risk of mental health, because those who said that they had no control over their future or didn't even know what they want to be when they grow up, those were more likely to have some form of depressive or anxiety or PTSD. Yeah, so that could be a simple way to even just screen and check. Yeah.
Excellent. Thank you for sharing those examples and also techniques. Very, very, very helpful. Thank you so much, Monica.
Thank you.
Okay, so over to you, Raphael, to introduce our next speaker.
Thank you so much. Thank you so much, Monica, for the wonderful presentation. It was so insightful. We could not take all the questions on the chat box, but we'll get back to them during the panel discussion. So as we welcome the next As we welcome the next speaker, abstract presenter, also keep in mind to keep on writing the question that comes up so that we can get into the presenters later on. Our next abstract presenter is none else but Sharifa Nalugo from Uganda, and her abstract is titled The Psychological Impact of COVID-19 on Pregnant Adolescents and Young Mothers. So warm welcome, Sharifa Nalugo.
Good day, everyone. My name is Nalgo Sharifa. I am from Uganda and from Joint Clinical Research Center. I'm a peer supporter, and I'm being supported by Pata to do this presentation. COVID-19 lockdown has made it difficult to access critical health services like psychosocial support, and with lockdown have restricted transport, interrupted treatment, and of course distress on household. With many facing a lot of challenges, this has left the normal support of services that we've been giving unattended to. This has left young mothers and, pregnant adolescents at most risk. And within the group that I support, there has been so much distress, anxiety, and psychological torture created from the COVID-19 situation. Many have not been able to get health services that they need or their babies, and they have interacted their ARVs, creating increased risk for mother-to-child transmission. I am now going to tell you about a program we've been able to use called ABCD. As a peer support, I work hard on trying to make sure that my peers, especially young mothers, are supported, and I provide them with ABCD of thinking healthy. I'm going to share how the ABCD pilot project and the tools I got there helped me provide support to my young mothers. So ABCD is a mobile app that provides package of care to pregnant adolescents living with HIV in form of support groups. It is implemented by facility-based peer supporters. This is normally done in small groups, but during COVID, we are not able to do so as we regularly done. And then we use the app and its tools to provide telephonic support to individual moms when we are not able to meet or come together. The ABCD tool provides me as a peer supporter with tools on my phone that helps me address the mental health needs of young mothers living with HIV in 4 ways. Number one is ask the A. This helps me ask a set of questions and to check into access on how our young mom is doing and what her psychosocial needs are. Number two is B. This tool gives me 8 structured content sessions which I use to boost or help the young mothers to think things in a more positive way. We call it thinking healthy or happy thoughts. And this is based on a WHO thinking. Then number 3 is C. C is for connect. An important part of the conversation as a group or with an individual is making sure that the young mother is linked to another support where there is need. It can be an NGO, a clinic, or the PATA support team to help and provide support for her and her baby. This for discuss, which is the last one. I can interact and chat with other peer supporters through the app, tell them what's happening and how I found the session. So now I'm going to tell you about how ABCD works. ABCD is a mobile app and uses a smartphone. I can log in using my own peer support code, and the ABCD provides me with a structured curriculum for me to follow within the groups that I can also use with individuals. Each session has different focus and provides key questions, things to think, talk about, exercise, and things to practice even for the next session. After each session, I can record a few things in the app. I can do all this offline, and when I do get internet, the information is sent back automatically to the PATA support team. Here you can see ABCD in action. Some of the most important things in the ABCDs that I've most enjoyed is that as peer supporters are a center of everything. We were part of developing the content and testing the app. We're also able to change some things in the final version. It is a tool for me, the peer supporter. It helps me do my work and has made me more confident and helped me prepare for every session or every group sessions and individual ones. I work very closely with the clinic staff and they support me along the way, especially when I think there is a problem that is too much for me to manage or handle. We will also get to share information with other peer supporters that are in other countries, and sometimes you get to meet at the Pata Youth Summit, certainly not this year because of COVID situation. This gives you an idea of all the areas we cover in our sessions. You can see this focuses mostly on psychological well-being of a mother and how she can learn and cope better with the change of becoming a mother during her teenage years. This is more of trying to focus, it tries to focus on positive thinking and trying to shift the negative thoughts to happier ones. It also focuses on building support and resilience. Who can take part in ABCD? ABCD, if you are a young mother, 18 to 24 years, you are accepted to participate in the ABCD, and mothers of that category, we are enrolled in the ABCD pilot, and we are hoping that in the nearby future we could enroll much young mothers, because we've had cases of 15-year-old, 14-year-old coming to the clinic and wanting to take part in ABCD, but because of their age, they could not be allowed in the pilot. There is also not enough being done for this group of young mothers, and they are often forced to attend antenatal care or transition to adult services when they are pregnant. This is very hard for a young mother who sometimes rather not return to the clinic because they fear being scolded or the community members looking at them. As we are doing a pilot study, 183 young mothers participated in Thinking Health program, and they were enrolled in the ABCD Thinking Health program. Approximately 52 sessions were conducted across 4 countries, that is Uganda, Zambia, Malawi, and Tanzania. And we started in March last year, and severe cases in Uganda and Zambia were picked up through the ABCD program, and young mothers were referred to professional care. Feedback on ABCD has been so positive and has been helpful to me as a peer supporter, making my engagement more, interactive and direct with the young mothers. So now I'm going to tell you how we were able to use ABCD to provide psychosocial support to the young mothers during COVID-19 period or lockdown. Even though we could not run the normal ABCD groups in COVID, we could use other information and the tool to support as normal, either meeting through groups or in video, text, and chat. We'd still go through exercises, even if on phone. I could send information and educate young mothers on and correct the misconception they had around COVID-19. I could still link young mothers to health providers if we felt there was, a serious problem. And most importantly, we could, check in and encourage and support, the young mothers every day that went on. Now I'm going to tell you about the challenges that we faced as I was implementing, this ABCD during lockdown or COVID-19 lockdown. There were so many challenges since we had to adopt to digital or virtual that we weren't even used to doing. And to many young mothers who didn't even have the phone or were not accessible, like, near where I stay, we could not be able to continue having the talks. But those that had the phone and I could reach, internet, data and airtime were a challenge. And even sometimes privacy in one's homes to be able to talk affects the ability for the young mothers to continue sessions, and we had to be flexible, and I was able to support as when most convenient. I noticed that isolation, stigma, and silence cause mental health problems. And with the ability to connect remotely is so important. Physical contact, even if at a safe distance, is important as well. Sometimes the cases needed more professional support, And I was able to reach out to the clinic supervisor or PATA staff support for guidance. And just to say, I think in the nearby future, if we could adopt this tool more, it could also be shared with mothers and use it directly. There is lots of opportunities with ABCD. We used it, in lockdown, and we were even teaching your mothers on skills in that could help them, make a living, since they were all, not going to their workplaces and they had to get money to feed their babies on a daily basis. So we managed to train them and in 2 paper bags, and then to some that could reach where I was staying, I trained them into making a face mask at my fashion house that I found it. So they could come and learn how to make them and sell them, and they could get, what to eat for them and their babies. As I conclude, I just want to say a thank you to Team PATA, the staff of JCRC, and to all my fellow peer supporters that have supported me during COVID-19, to all the people that I've gone to and you've helped. Thank you so much. Keep up the great work.
Thank you so much, Sharifa. Thank you. Thank you very much for your presentation. And again, another example of an intervention, right? So for those programmers or researchers, policymakers, people looking for kind of inspiration in terms of, how certain programming has been adapted or new innovations, like it's great to be able to hear about the ABCD app and how peers are supporting each other to be able to screen around mental health and then to provide ongoing support. There's a question for you, Sharifa. Is the app available for free download?
Thank you, Georgina. The app is not available for free download now. Since we are doing a pilot study, we're trying to study how best can the app work. So it was just a pilot study and not free for everyone to download. And as I said, ABCDs is strictly in health facilities, so not to everyone that can be able to access it.
Yeah. But maybe if people want to know more about the ABCD app, they can probably find that on the PATA website, right? So maybe they can go and have a look there. Yeah.
Yes, on the PATA website.
Awesome. Okay, so believe it or not, everybody, we are actually running out of time. And so what we're going to ask, Raphael and I are going to ask people to do is for all our presenters to put on their videos. And presenters, it would be great if, you could just share with us one of your takeaway message or recommendation, in fact, to all those that are listening, as you do the work that you do around supporting the mental health and mental well-being of adolescents living with HIV. It would be great to hear, what your tip is, your recommendation for those who are listening. So let's start with yourself, Sharifa.
Yes. My take-home message will be that to everyone that is watching, mental health is all about, being there and supporting someone who is going through it. So if you're someone who is able to support, give him all support that you can. It's all about support that you can get out of this. And maybe appreciation. Some of the people are facing mental health challenges because they are not appreciated. They feel they are not worth. They feel they are not important in the society. But if we make sure that we appreciate each and everyone, even if it's a single thing, I like to always appreciate Georgina on the way she's joyful. I mean, that can encourage her and to keep going and going and going. I mean, so a little bit of appreciation and support is all I can say for now, and can help us get through mental health issues.
Yeah, amazing. And that was a key message today, the importance of that support system, right? No matter what intervention there is, about the support system. Okay, let me pass on next to Monica.
Okay, thank you again, Georgina. I think my concluding remarks will be that an HIV diagnosis itself is quite a heavy burden to live with, especially as a young person or any chronic condition for that matter. So it's not just about medication. Like what I see often in facilities is like just questions around, have you taken your medication? Are you adhering? And we forget to ask, how are you today? Something as simple as that. Yeah. So I just want to say, let us be cognizant of this. And like people are going through a lot in general. And then a young person who's going through a double vulnerability, it's even more so. And then also, let's not forget young boys. As much as we program everything around young women and mothers, like let's not forget young boys in the bigger picture. Yeah, thanks.
Awesome. And that was a message that came through from Prosper, actually, about young boys. There's a whole set of issues that happens, that society expects things of boys. And that's a whole nother area. But I have to say, Monica, one thing I will remember is, you know, this point about providers asking young people about their aspirations, and that in itself as an intervention means that they're able to kind of look ahead to the future and look ahead to beyond today, you know. So yeah, thank you. Nicola.
Thanks, Georgina. I would wrap up with, we will not achieve what we're trying to achieve in HIV, certainly for adolescents living with HIV, if we don't address mental health. I think we're starting to get really important prevalence data. We're showing it's correlating with poor adherence and, of course, poor quality of life. So we have to be investing in mental health for young people's well-being, but also for HIV outcomes. And I would also say, we haven't got time to talk about it now, but we need to be very careful about language. We all want mental health. We want good mental health. Mental health tends to get boxed into this, what some people mean as poor mental health or mental health conditions. So we need to really think hard collectively as a global community about how we talk about, how we define mental health. We want optimal mental health for adolescents, and then we need interventions that help to promote optimal mental health, but also to identify early and respond to those with mental health conditions. Thanks.
Thank you. Thank you very much, Nicola. And thanks for sharing, you know, just the experience of, by doing this enhancements in terms of the peer supported training, the CATS trainings, and, you know, bringing on board the PCT, problem solving therapy, just how that in itself can improve the mental health and well-being of your adolescents living with HIV. So that's a great concrete intervention that participants would have heard today. Okay, and Cindy, we gave you the first word. We are giving you the last word. Over to you.
So thank you very much, Georgina. So for me, maybe two things have stood out for me. First of all, I had never thought of it that way. Mental health could be solved that way, but that is a very concrete, like you just said, that's a very concrete intervention.
Cindy, we missed.
Can you hear?
Well, we missed when you said what it was. We literally missed that bit. Starting.
No, I was just saying, like, so I would say like the PCT intervention is a very good example of how we envision an intervention, well outlined, well put forward. So that is something that we should be looking out for, because I think it's simple because it starts with the peers themselves. And then if it's from the peers, then they're able to influence other young people easily than if we just put it as the general population. And second of all, I just realized that as the speakers were speaking, that every time when young people go to a health facility and everything, all they get is medication. You have to realize that at the end, all the medication we want, but if it is not effective if we are not mentally okay. The moment we start not being mentally okay, we will lose the whole idea of being actually healthy. Yeah, and that is what I have gotten from all the presenters.
Thank you. No good health without mental health, right? So thank you very much, Cindy. And thanks to all our presenters today. for sharing and for sharing very openly, also from very personal perspectives. So thank you very much. And I will pass it on to my amazing co-chair for the final closing.
Okay. Regina, have you handed it to me?
Yes. Yeah.
Great.
So that's you, Raphael. Back to you.
Thank you so much. I almost lost you at the end, but it was really great to follow up this very wonderful conversation. I can't imagine how time has not been enough to discuss all this. We thought we could have some much more time to discuss it further, but we all know it's complex and very important issue. That's why this conversation keeps on going, and we hope we can keep this conversation going even after this session. So thank you so much to Cindy, very wonderful abstract presenters, and this has really been a good even lesson for me. And I've seen how mental health is an urgent issue. It affects, as Sid has said, if you're not mentally fit, you cannot even deliver well your activity. So it really needs to be treated as a matter of urgency, and young people should be taken in that process. So as we wind up, we would like also to thank our wonderful sponsors who are making this possible, and specifically to thank VIV, Gilead, and Mylan, who have been very wonderful sponsors making it possible today. And for all of you who have tuned in today to follow up this conversation. We're also going to have another session, because this is a series of virtual workshops on HIV and adolescence. So on Thursday, Georgina, we're going to have another session. Yeah, we're going to have another session, and it's going to be the same time as we started today. And we're going to have chairs, will be Linda, Gail, we'll also be having Zoe and Lazarus, who will be chairing that session. And it will be on the best research is research with us and by us, participatory research practices. So it's going to be a very wonderful session, and make sure you're not going to miss that. So back to you, Georgina, so that you can welcome us and take us to the next session, which is poster viewing.
Yeah, well, exactly. So now there's poster viewing, and please all join and learn some more about other interventions in this particular area. And just as a way of closing, there's a video, and it's a video by Afrique Jandiri, and it's about superpowers. So Nicola, just tell us like 1 second about this video.
Okay, 1 second, I'll be super quick. We're excited to be launching Together Superpower. It's written and developed by young people living with HIV, together with Zimbabwean artists. They wanted to remind everybody that whilst we hear a lot about the data and statistics, young people are more than just a number. They wanted to remind us about their phenomenal lives. And in this song and video, the lead singers have been animated, and we see their superpowers, their extraordinary powers. They're ready to support other children, celebrate their own lives, strengths, their uniqueness and their diversity. So they remind us they are superheroes capable of so much. I want to thank UNICEF and Maruva for making this possible, the incredible young people involved, the Zimbabwean artists that made it possible. And as you're listening, just put in the chat box, send us a message, tell us what your superpower is. But this is a real celebration of young people. They are more than just a number. Thanks.
Amazing. Thank you. And bye, everybody. Thank you.
Am I just an equation? Or just the sum of my parts? Whenever you go near me, you don't hear my heart, and it beats. A million constellations, a dream that still unfolds. And it's hard to wake up, and it's hard to be bold when you leave me on my heart. Instead of running on the numbers now, why don't you come and check my name first song? Or maybe look me in the eyes, mama, instead of writing your papers from far away. 'Cause I'm so tired of these signals on. They make no sense to my life for sure. I'll take my powers to the masses broad, and you just sit there and roll your dice from far away. You're far away, 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 you're far away. You should get to know me better. Life's a business and show you right. And I know one fights my battles better than I am gonna still do
Look up, Hona. Divide the skies into 88. Rising like the new design. Come and watch me demonstrate. Kubata needs a shades. Kuflex sema gates. Dishmanya mucha denga. Dashika mucha tenda. Chigokam, Hona. Razarova Pona. My superpower keta. Habasati Vambo Ona. Habasati Vambo Ona. Ausati Vambo Ona. Rumeri